New York, Churchill Livingstone, 2008:1764-5. COJB, ETAL. Carcinoma. 51, a 77-year-old man with obstructive uropathy and truss biopsy-proven prostate cancer was scheduled to have an MRI for local staging of the known prostate cancer. Which one of the following statements regarding identification of prostate cancer by dynamic contrast enhancement, DCE, is true? A. Fast enhancement and slow washout suggest prostate cancer. B. Slow enhancement peak and slow washout suggest prostate cancer. C. Slow enhancement and fast washout are highly suggestive of prostate cancer. D. Small prostate tumors are detected easily. E. The higher the tumor grade, the greater the grade of enhancement. 52, a 40-year-old man presents to his general practitioner with intermittent left leg pain and stiffness of 5 years duration. Plain radiograph reveals eccentric and irregular sclerosis along the medial aspect of the distal femur, crossing the joint into the adjacent tibia. Cortical new bone formation along the outer aspect of the cortex is also seen, with an appearance similar to flowing wax. Wax. In addition, there are adjacent atypical pulmonary metastases, spectrum of radiologic findings. Radiographics. 2001, 21-240317. 51e. The higher the tumor grade, the greater the grade of enhancement. DCE MRI evaluates the vascularity of tumors by providing quantitative kinetic parameters that reflect the flow of blood and the permeability of the vessels. DCE MRI increases the specificity of prostate tumor detection. Tumors show early enhancement and early washout of the contrast agent. The higher the tumor grade, the higher would be the permeability parameters, nitrans wash-in, KEP washout. A disadvantage of DCE MRI is that small, low-grade tumors may not demonstrate abnormal enhancement. Furthermore, abnormal enhancement patterns can also be seen in patients with BPH, which can make assessment of the central gland difficult. However, in the glandular peripheral zone and anterior gland, DCE MRI can be helpful in identifying lesions that are not suspected on T2 weighted image. T2 weighted images. The degree of enhancement on DCE MRI correlates positively with tumor grade. Turk BB, ETAL imaging 219. 52a. Melorhiostosis. Melorhiostosis is a very rare non-hereditary disease of unknown etiology. Patients can present with pain and restricted movements of the joint, but the disease is usually asymptomatic and is discovered incidentally. Some patients may have thickening and fibrosis of overlying skin, resembling scleroderma or joint contractures. Radiographic features include dense irregular bone running down the cortex of a tubular long bone, which can cross the joint. This has the appearance of flowing/molten wax and is usually limited to one side of cortex, although the internal or external cortex may be affected. The lower limbs are the most commonly affected. Other notable features are discrepant leg length on the affected side and the presence of adjacent ossified soft tissue masses. 27. Soft tissue masses, 27%. Dannert W. Radiology Review Manual. 7th N. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011. Sutton D. Textbook of Radiology and Imaging. 7th N. Edinburgh, Churchill Livingstone, 2003. 53b. Multiple sclerosis. The spinal cord is known to be frequently involved. Ossified soft tissue masses. Which of the following is the most likely diagnosis? A. Melorhistosis. B. Osteopoikilosis. C. Fibrous dysplasia. D. Osteoarthritis. E. Osteopetrosis. 53. A 37-year-old woman presented to the A&E department with acute worsening of arm weakness and pins and needles at the C4/5 levels. MRI of the spine revealed an elongated area of high T2W signal change, which showed variable contrast enhancement. There was no. Chapter 7. Test paper 4, questions. 190. Associated expansion of the cord and CSF obtained by LP had earlier shown oligoclonal immunoglobulin bands. What is the likely diagnosis? A. Lyme disease. B. Multiple sclerosis. C. Sarcoidosis. D. LCHE, lymphoma. 54. A9. Involved in MS or in combination with lesions in the brain, as many as 25% of cases have been found to involve only the spinal cord. Most spinal cord lesions occur in the cervical cord. Cervical spinal MRI is particularly useful when the patient is suspected to have MS and brain lesions are absent. On T2 weighted spinal imaging, most plaques are peripherally located, commonly dorsolateral, and less than 2 vertebral body segments in length. The lesions tend to be multifocal and present as well-circumscribed foci with an increased T2 signal intensity. With acute spinal cord lesions, enhancement is frequently seen. Spinal cord atrophy, which may reflect axonal loss, may also be observed and is believed to be an important element in disability. Though rarely seen in other diseases, asymptomatic lesions of the spinal cord can be present in MS and may help lead to the correct diagnosis. Unlike its applicability to the brain, FLAIR imaging appears unreliable in the detection of MS. Lesions in the spinal cord. The short inversion time inversion recovery (STIR) sequence has been found to be sensitive for lesion detection, particularly diffuse lesions. GEY, multiple sclerosis, the role of MR imaging. AJNR AMJ Neuroradiol. 2006, 27, 611 65 76. Poonawala ETAL cervical spinal cord lesions in multiple sclerosis, T1, weighted inversion recovery MR imaging with phase-sensitive reconstruction. Radiology. 2008, 246, 1258 64. 54. D. Autoimmune hemolytic anemia mature cystic teratoma can be associated with complications from rupture, malignant degeneration.